Hello there. So we have this treatment of megaloblastic anemia. So first of all, what is megaloblastic anemia? As we all know, it is result of vitamin B12 or folic acid deficiency, but it has not been named like iron deficiency anemia. That means it has not been named folic acid deficiency anemia or vitamin B12 deficiency anemia. It has been named megaloblastic anemia. Why? Because the lack of both of these nutrients produce indistinguishable features to the RBCs in blood vessels as well as bone marrow, and that typical structure is known as megaloblast. So in other words, the term megaloblastic anemia denotes peculiar structure of RBCs, precursors in bone marrow and peripheral blood, most often due to vitamin B12 or folic acid deficiency. So they produce megaloblast. So what does the megaloblast look like? As the name suggests, megaloblast is the big RBCs without mature nucleus or with immature nucleus. So immature nucleus is because the RBC, though continues to grow, cannot divide because this DNA synthesis is impaired, and this DNA synthesis is impaired because of lack of these raw materials for DNA synthesis, vitamin B12 and folic acid. And most often, since it hinders the cell synthesis, this vitamin B12 and folic acid deficiency hinder the blood cell synthesis, along with decreased RBC synthesis. We may also see decreased WBC synthesis and platelet synthesis, giving rise to bicytopenia to tricytopenia or pancytopenia. So what is the role of this? To understand the role of this folic acid and vitamin B12, we have to be thorough with this diagram. In this diagram, what we see is, we have to understand is that dietary folates, the green vegetables in diet, liver in diet, will always provide us with this methyl tetrahydrofolate. This we obtain from the diet. We always obtain methyl tetrahydrofolate from diet, and for the sake of DNA synthesis, this methyl is not good enough. It has to be converted into methylene. So what our body does is, it will get rid of this methyl so that it becomes tetrahydrofolate, and this tetrahydrofolate is easily converted into methyl tetrahydrofolate, and methylene tetrahydrofolate. So this methylene is then provided to either purines or to pyrimidines, and thus the DNA synthesis takes place, and it is easily methylene, the single carbon. Single carbon is easily transported to this purine and pyrimidine. While doing so, this methylene tetrahydrofolate converts into dihydrofolate, and this dihydrofolate can be reconverted into the tetrahydrofolate by dihydrofolate reductase, and it is also known as folate reductase. It's the same. So folate reductase. So the thing is happening like that. Now this is the importance of folic or folate. So this is why the folate is important for purine and pyrimidine synthesis. No folate means no purine and pyrimidine synthesis. So what is the role of vitamin B12 then? Vitamin B12 means cobalt containing vitamin, or cobalt containing vitamin. So cobalamin, it is a methyl acceptor, and it will take the methyl from this methyl tetrahydrofolate of diet and converts it into the methyl cobalamin. and later it will get rid of this methyl by transferring it to the homocysteine, which converts into methionine. Now we can now this is the story, and so lack of vitamin B12 or lack of dietary folate, these both means no purine, no pyrimidine synthesis, no purine, no pyrimidine synthesis. So one thing that is important is we can substitute the if it is the megaloblastic anemia, I suppose, which you have understood, the lack of the megaloblastic anemia, lack of DNA synthesis by either vitamin, either by decreased amount of dietary folate or decreased amount of vitamin B12. And if it is due to the vitamin B12, we can still correct vitamin B12 megaloblastic anemia with vitamin B12 lack with folate, not dietary folate but drug folate, folic acid drug. We can control, or we can get rid of the megaloblastic anemia due to vitamin B12 deficiency by substituting the folic acid as the drug, because folic acid will bypass this dietary folate mechanism and will go into the circle directly because this folic acid will be converted into diethyl by folate reductase, and which is further converted into tetrahydrofolate, and then onwards the cycle goes. So even in spite of vitamin B12 deficiency, we can correct the megaloblastic anemia with folic acid alone. But what happens is, in lack of vitamin B12, this homocysteine cannot be converted into methionine, and too much homocysteine or hyperhomocysteinemia will give rise to the symptoms of neurological features, like there is something known as subacute degeneration of spinal cord as well as neuropathy. All these results in lack of vitamin B12. So these features cannot be prevented by folic acid substitution. And besides, hyperhomocysteinemia, they say, is also associated with atherosclerotic vascular disease. So these are the two problems of vitamin B12 deficiency. If you substitute with folic acid, which still remains this neurological features and maybe hyperhomocysteinemia resulting in vascular atherosclerotic disease. And besides, all the folate in the body that is provided by the diet will get a trap known as will be in the body will be trapped in the body in form of methyl tetrahydrofolate, and this is known as methyl folate trap. In absence of vitamin B12. This is it. The source of vitamin folic acid is spinach. Spinach means palungo, and folic acid is the term derived from leaf. Foli means leaf in Latin, and chemically it is pteroyl glutamic acid. So this is a pteridine ring, and which has an glutamic ring, and this parabenzoic acid is not referred. Only this pteridine ring and glutamic acid are referred. So it is folic acid is chemically pteroyl glutamic acid. So requirement, a normal human being would require 0.2 mg per day. Special conditions like pregnancy, lactation require higher amount, that is 0.8 mg per day. Richest source are green vegetables, yeast and animal body store it in liver, but only 5 to 20 milligram is there. So for a normal patient, the requirement may be fulfilled in about, if it is 10 milligram, it will be fulfilled in some 50 days. So they say that human body in liver we have stored for 1 to 6 months. So what are the deficient population? Since it is stored in liver disease is the deficient condition. Alcohol hinders the liver, so it is also one of the deficient condition. And pregnant woman, the demand is higher, and 0.8 mg per day, so it is also one of the condition in which there may be deficient. And hemolytic anemia, because there is high turnover of the RBCs are manufactured and destroyed very fast, so it is one of the conditions. And those undergoing renal dialysis, because kidney will or rather dialysis will remove the folic acid. So what it may be the result of deficiency? If the mother is deficient in folic acid is deficient in folic acid, which is also a vitamin. So if the mother is deficient in folic acid, then we have neural tube defects. Example of neural tube defects are spina bifida and anencephaly. Anencephaly is the person, the baby is not having the cranium, and spina bifida is the nervous materials of the vertebral column come out of the nervous system, come out of the vertebral ring, and that is known as spina bifida. It has also different classes, and besides the folic acid deficiency in mother is also associated with the congenital anomalies in heart and orofacial region. So what are the indication of folic acid? One is folic acid dependent megaloblastic anemia, and another is pregnant woman for the prevention of neural tube defects and congenital malformation of heart and orofacial region. And also in the very same way, the fast treatment of iron deficiency anemia institute bricks hematopoiesis or hemopoiesis, which may unmask the deficiency of these folic acid. So it is also one condition. And methotrexate is a drug which is given in different conditions, from molar pregnancy to abortion to different breast cancer, etc. So in this condition we have to bypass the effect of methotrexate toxicity. We give this drug because methotrexate, what methotrexate in toxicity does is it will stop all this folate reductase. So we and the tetrahydrofolate conversion is not possible, so we have to give the activated form tetrahydrofolate, not folic acid, in these conditions. So we have, as a product of so we have this methotrexate toxicity, we can give tetrahydrofolate, and all these are tetrahydrofolate: folic acid, leucovorin, cytoboron factor. So these are the brand name of the tetrahydrofolate, so we have to give the tetrahydrofolate. Similarly, 5-fluorouracil will stop thymidylate synthase, so it may stop the DNA formation even in the normal cell. So to facilitate the normal cell, we give this folic acid, even in case of 5-fluorouracil. So ADR of folic acid, this is non-toxic, it is pregnancy category A, and injection rarely cause sensitivity reaction. So this is the only one ADR. Injection might cause sensitivity reaction, and so interaction, it reacts when prolonged therapy with anticonvulsants like phenytoin, phenobarbital, or primidone is done, and or oral contraceptive is done. It interferes the absorption and storage of folate. Contraindication and precaution of folic acid. This is parenteral route and anticonvulsant and oral contraceptives. So contraception, so as quite understandable, what are the contraindication? Parenteral route and anticonvulsant and oral contraceptives, as mentioned earlier, due to the hindrance in absorption and storage. Anticonvulsant and oral contraceptives are not given, as far as possible avoided with folic acid. Vitamin B12. Vitamin B12 is the most complex of all the vitamins, and it has centrally cobalt metal. It has centrally placed cobalt metal, so it is called cobalt containing vitamin or cobalamin. So it is synthesized only by microorganisms and may be stored in the liver, kidney of the higher animals, and of the higher animals including human being. Liver, kidneys also abundant in sea fish, egg yolk, milk, seed, all the animal products. And the only one vegetable source is legumes, because it has harbored microorganisms in its root nodules, so it will take this so it will acquire this vitamin B12 from the roots microorganisms. So legumes are one of the sources, otherwise it is only animal sources. And what is the requirement? 3000 to 5000 microgram and is stored in the liver, and 2 microgram per day is used per day. So it takes around 5 years for the store to get depleted if the person doesn't take any form of vitamin B12 from today. Pharmacokinetics, let's forget about this R binder, and we take it orally, and it will bind to the intrinsic factor secreted by parietal cells of stomach, and then it will bind, and in the bound form of vitamin B12 and intrinsic factor, it reaches the intestine or the ileum, and in the ileum the intrinsic factor is left behind, and this vitamin B12 is absorbed, and it reaches and it binds to the transcobalamin 2 in the blood and reaches its destiny. So this is it is first intrinsic factor bound with intrinsic factor in ileum, get absorbed and binds to the transcobalamin 2 in the blood of ileum. So what might be the deficiency conditions? It is quite common sense, because the gastrectomy is one of the conditions when it may be deficiency, because we don't have intrinsic factor then secreted by parietal cell, and destruction of gastric parietal cells by autoimmune process known as pernicious anemia. So this is the same way, it is also the deficiency condition, because no intrinsic factor. And if we have loss or malabsorption in the absorptive mechanism of distal ileum through which it is absorbed, understandably in malabsorption syndrome, inflammatory bowel disease, small bowel resection, or fish tapeworm, also known as diphythobothrium latum, which will absorb the vitamin B12 there. And strict vegetarians after many years without even egg, meat and dairy products. So manifestation of deficiencies are megaloblastic anemia 1 and other. The GI epithelial cells are also undergoing high turnover. So these so glossitis and others may be result damage to the epithelial structures. And similarly, I mentioned you, due to the lack of vitamin B12, due to the lack of methionine metabolism, or due to accumulation of homocysteine, we may have this subacute combined degeneration of spinal cord in vitamin B12 deficiency, and peripheral neuritis, and even psychiatric manifestation. So uses of vitamin B12, megaloblastic anemia, and tobacco amblyopia is another condition. Tobacco amblyopia and megaloblastic anemia, and other questionable use are we use a mega dose of vitamin B12 in neuropathies, psychiatric disorders, cutaneous sarcoid, and general tonic. So these are the conditions. One is megaloblastic anemia, we understood. Tobacco amblyopia is another condition we have to remember, and other questionable use are sometimes it works and sometimes it does not. If it is due to neuropathies or psychiatric disorders or cutaneous sarcoid, or due to vitamin B12 deficiency, then it might work, this vitamin B12, otherwise it does not. So it is a questionable use, and so it is often incurable, as it is mostly due to pernicious anemia, or maybe due to gastrectomy or ileal resection, malabsorption syndrome. So these are most of the time unrecoverable or incurable condition. So we require lifelong treatment with parenteral vitamin B12 in the form of either cyanocobalamin or hydroxycobalamin. Hydroxycobalamin is preferred because it is highly protein bound and remains longer in the circulation, and dose is 1 milligram or 1000 microgram daily for 2 weeks, and then 1 milligram or 1 microgram every monthly. So this is the dose of vitamin B12, hydroxycobalamin. So what are the ADR? Even the large doses of vitamin B12 are safe. So only the anaphylaxis or anaphylaxis, again it might be due to the sulfite content in the formulation. So contraindication and precaution, we have to avoid the IV injection for the fear of this anaphylactoid reaction. So my question to the students is, the megaloblastic anemia from vitamin B12 deficiency and folic acid deficiency is morphologically indistinguishable. So and it's always better to assess the folate status in the serum or the RBC, whether to see whether the folate status is normal or not. But my question is, if the facility to assess the folate status in serum and RBC is not available, how will you distinguish between the two conditions? So this is the answer. One, we have to see the susceptible populations, those who have undergone the gastrectomy or who have undergone ileal resection, those who are strictly vegans are might have vitamin B12 deficiency, and pregnant women, alcoholic, or having liver disease, they might be suffering from folic acid deficiency. And folic acid deficiency, megaloblastic anemia develops faster, that is within 3 to 4 months, because the stored in body is very less, and it is a vitamin B12 deficiency anemia. It develops in long term. So this is vitamin folic acid is faster. And third one is this neurological abnormalities is only seen in vitamin B12 deficiency, not in folic acid deficiency. So thank you.